Welcome to the ASCO Guidelines episode of the ASCO University Weekly Podcast. My name is Ornob Roy, and I am an assistant professor of urology at the Levine Cancer Institute in Charlotte, North Carolina. Today we feature an ASCO Guideline, Management of Small Renal Masses. The management of small renal masses has become increasingly complex and subsequently has undergone more scrutiny over the last 10 years due to the increased rate of incidentally found tumors and a more elderly and comorbid population. The purpose of these guidelines is to provide evidence-based recommendations for the management options for patients with small renal masses, as defined as renal tumors less than or equal to 4 centimeters in size and suspicious for primary renal malignancy. Up to 25% of these masses will turn out to be benign, and another 25% will have an indolent natural history with limited metastatic potential. This guideline does not address the management of confirmed benign tumors such as image-proven angiomyolipoma or biopsy-proven oncocytoma. This guideline is not presumed to be inclusive of all possible treatments or as a statement of the standard of care. To develop these guidelines, an expert panel reviewed the literature on Medline between 2000 and 2015. 83 studies met eligibility criteria. The majority of these were retrospective, 3 were randomized controlled trials, and 2 were prospective comparative trials. The recommendations in these guidelines are based upon answering 3 primary clinical questions. Clinical question 1. When is renal tumor biopsy indicated? For the purposes of this guideline, renal tumor biopsy refers to a core biopsy, given the superior diagnostic rates compared to fine needle aspirate. All patients with a small renal mass should be considered for renal tumor biopsy when the results would alter management. Current radiographic imaging consisting of MRI, CT, and ultrasound cannot make an absolute diagnosis of cancer. A recent systematic review showed median overall diagnostic accuracy rate to be 92%. Predominantly cystic masses or masses suspected to be urothelial cancer should not undergo percutaneous biopsy. For patients undergoing tumor ablation, pre-ablation renal tumor biopsy should be performed to establish a diagnosis and the appropriate follow-up schedule. Clinical question 2. Who should undergo active surveillance? The absolute indication for active surveillance is for patients at high risk for anesthesia or intervention or with a life expectancy less than 5 years. Relative indications for active surveillance include high risk of inducing end-stage renal disease with intervention, small size less than 1 centimeter, or life expectancy less than 10 years. The risk of metastatic disease is low during surveillance within the first 3 years. The average growth rate of 3 to 4 millimeters per year is not an indication of histology, as both benign and malignant small renal masses will grow at similar rates or not at all. Possible triggers to intervene should be growth rate greater than 0.5 centimeters per year or reaching 4 centimeters in size, as these are more indicative of aggressive disease. Clinical question 3. What are the optimal indications for undergoing partial nephrectomy, radical nephrectomy, or ablation, and what is the impact of these procedures on renal function? Partial nephrectomy is the preferred treatment and should be offered to all these patients if they possess a tumor amenable to this approach. Observational studies have consistently demonstrated benefits in preservation of renal function and overall survival partial nephrectomy while maintaining equivalent oncologic outcomes to radical nephrectomy. Percutaneous thermal ablation should be considered as an option when complete ablation can be achieved, and this should be preceded by a percutaneous biopsy. In addition to comorbidities, renal mass location and size are associated with higher procedural complication rates, although overall complication rates are superior to surgery. Ablation seems to offer superior functional preservation relative to surgery. Repeat ablation after ablation failure carries similar rates to success in properly selected patients, whereas partial nephrectomy after ablation is difficult with high rates of conversion to nephrectomy. Radical nephrectomies for small renal masses should be limited to patients with significant tumor complexity, which may result in unacceptable morbidity after partial nephrectomy, and even in these cases, it should be considered to refer these patients to centers with high partial nephrectomy experience. Referral to a nephrologist should be considered for post-treatment GFR less than 45 or progressive chronic kidney disease, especially with proteinuria. We as clinicians should incorporate shared decision-making with patients in using these guidelines due to the opposing forces of oncologic benefits of intervention versus potential short and long-term complications of intervention in this elderly and often comorbid population. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information, be sure to check out ASCO University's quarterly e-learning series on ASCO Guidelines by visiting university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.